Hello. In this video I'd like to share with you the recent findings from a study our research group conducted in the central region of Uganda looking at the prevalence of malaria in adult women. My name is Sergey Yegorov. Although great progress has been made toward reducing the burden of malaria in the last 1.5 decades, this disease remains a leading cause of morbidity and mortality worldwide, but especially in Sub-Saharan Africa, which was home to about 90% of all malaria cases in 2015. Malaria is a mosquito-borne disease caused by protozoan parasites of genus Plasmodium. These parasites infect red blood cells. Most morbidity in Sub-Saharan Africa associated with malaria is caused by Plasmodium falciparum. A typical clinical hallmark of malaria is fever, accompanied by other symptoms such as headache, vomiting, and chills, and if left untreated, malaria can be fatal. The gold standard of malaria diagnosis is light microscopy, which involves examination of blood smears. Light microscopy requires multiple prerequisites to be in place for it to be effective. And these prerequisites involve a light microscope and a very highly trained microscopist. These prerequisites are often difficult to maintain in limited resource settings, and therefore recently rapid diagnostic tests for malaria testing have been incorporated into the clinical guidelines of malaria endemic countries to aid with parasite-based diagnosis of malaria. As you can see on this cartoon, rapid tests are very simple basically test strips that use a small volume of blood and detect circulating Plasmodium antigens, and they give a readout for a presence or absence of malaria infection within approximately 20 minutes. There are molecular techniques available for diagnosing malaria, such as PCR. These techniques are the most sensitive methods out there, but probably at least for now, they're the least feasible to be for limited resource settings. This presentation is on malaria in Uganda. Uganda ranks 3rd in total malaria burden in Africa and 4th globally. Malaria prevalence in Uganda varies tremendously based on the region, but also on the techniques that are used by different studies to assess malaria rates in the populations, in Ugandan populations. Most studies in Uganda have been done on malaria in children, because children, especially young children, bear the brunt of malaria-associated morbidity and mortality. Therefore, data on adult malaria are actually quite fragmented. The objective of our study was to assess malaria prevalence among adult women with and without fever using public health services in Wakiso district. This region traditionally has been known as malaria hyperendemic, and the project I'm going to describe to you was a pilot project. It was a part of a larger study on the immune impact of malaria in adults. Just to give you a brief overview of the geographic location of the study site, Wakiso district is located on the shores of Lake Victoria and is home to semi-urban, rural, and fishing communities. Most recent studies on malaria in this region were done in pregnant women or HIV-infected individuals, and therefore the malaria prevalence in the general population is not very well understood. The participants for this study were recruited from 3 different clinics in Entebbe. The first group of participants were febrile outpatients of a major referral hospital. These patients were diagnosed with malaria based on recent history of fever and a positive test result that was done by hospital microscopists. The second group consisted of afebrile outpatients of 2 different clinics, and these outpatients were screened for the presence of asymptomatic malaria in this study. Women who knew that they were pregnant or HIV positive were excluded from screening. Both groups of participants were screened for malaria using 2 rapid diagnostic tests. Both of these rapid diagnostic tests met WHO performance criteria for detecting Plasmodium falciparum or mixed Plasmodium infections. All women in this study were also tested for pregnancy and HIV. As I will describe to you in a few moments, we were surprised that the majority of women diagnosed by the hospital as malaria positive were negative on the rapid diagnostic tests that we used, and therefore we conducted confirmatory malaria testing using light microscopy and PCR in a research lab setting. These are the clinical characteristics of study participants. Again, to reiterate, we have 2 groups of participants here: 86 women with hospital-based malaria diagnosis that also had a recent history of fever, and the second group was afebrile participants. What stands out right away is that out of 86 women with suspected malaria, only 2 were actually positive on the rapid diagnostic test. Interestingly enough, a large proportion of these women was also positive on pregnancy test. They were pregnant, 21% of these women. Among the asymptomatic participants, none were positive on the malaria rapid test, and a lower proportion were positive, were pregnant. To look in more detail at the testing algorithm for women that were diagnosed with malaria at the hospital, there were 86 of them. They were all tested by the malaria rapid test, and only 2 of them turned out to be positive on the rapid test. These 2 women were confirmed as malaria positive by research microscopy and PCR. They had Plasmodium falciparum infection. The remaining 84 women that were RDT negative were not confirmed by research microscopy, and only 1 of them actually was positive for Plasmodium DNA by PCR, and this person was infected with Plasmodium ovale according to the PCR result. This is an interesting observation because Plasmodium ovale is a more rare parasite in the region compared to Plasmodium falciparum. Now, it's important to note that all of these women that were diagnosed as having malaria at the hospital were also treated with antimalarials. Looking at the group with no fever, so the asymptomatic group, no malaria was detected among the 104 women using rapid tests, and this was also confirmed by PCR and research microscopy. The tests were negative by both, implying that malaria in the general population, the prevalence of malaria in the general population may be quite low. It's important to note that this study was designed as a pilot study and not as a true survey of malaria prevalence. Therefore, it has some limitations. For example, we didn't have access to all the samples for all of the participants. They were not stored, and therefore we were unable to perform PCR for all of these participants. RDT sensitivity is quite low for non-falciparum parasites, and we think that some cases may have been missed by RDT for parasites such as P. malaria and P. ovale. Nevertheless, we observed high rates of malaria overdiagnosis and treatment at a major hospital in Uganda. This is a major referral hospital, and we think that these findings may not be uncommon in this region or in other regions of Uganda and Africa. In fact, looking at the literature out there, we do find studies performed by other research groups which describe similar trends in terms of overdiagnosis of malaria in other parts of Africa. Importantly, a very high false positive rate of malaria diagnosis would be expected to lead to substantial malaria overtreatment with the ensuing possibility of adverse drug effects, as well as undermanagement of other potentially important clinical causes of fever. Overprescription of malaria drugs has implications for the emergence of parasite drug resistance, which is an important concern globally. In this study, we also observed that RDTs had been underutilized by the hospital staff, and this was mainly due to irregular supply and lack of confidence in RDT-based results. Based on the findings presented here in this study, a more rigorous quality control and is already being implemented for light microscopy at the hospital, but also regular use of RDT is being mandated in the routine practice of the hospital laboratory. We also did not observe any malaria in the asymptomatic population by different tests, and this finding should be further explored by other studies in the future and on a larger population sample. In many regions, malaria in pregnant women and children remains a major public health problem, and more efficient allocation of resources for treatment and eradication of malaria may be urgently needed. I'd like to dedicate this presentation to the memory of Dr. George Miro, who was a director of the UVRI clinic and who played a crucial role in the supervision of this study. I'd like to acknowledge the participants of the study, as well as the members of multiple clinical teams in Entebbe and my colleagues at the University of Toronto, but also the funders that provided funding for the study. Thank you very much.